welcome for our World Coma Day podcast. Fantastic. Well, everyone, I want to welcome you to this live session on World Coma Day 2025. My name is Claude Hemphill, and I'm a professor of neurology at the University of California, San Francisco, and along with Daiwai Olson, who's also on the session. We are co-chairs of the Curing Coma campaign, and today is the fifth World Coma Day. And one of the things that we need to always remind ourselves is that the first word in World Coma Day is world. And this is really an important time for us to share information, but also gain and share perspectives from around the world as we try to tackle this really major issue in neurocritical care and acute brain injuries of trying to cure coma, trying to improve the outcome of patients, and try to be very thoughtful and careful as we think about how we counsel patients and especially their families regarding coma recovery. So it's really a privilege to be here and to have our Asia Oceania chapter kind of kick off the first of these live sessions and that we're going to have on World Coma Day. Just a couple of things to remind folks about World Coma Day. We have some day of live sessions, such as this session, and we also have a YouTube archive that has over 70 videos that have been submitted from folks around the world. And these are a variety of things. Some of them are scientific presentations. Some of them are stories of hope from patients and families who are describing their journey with their injury or illness. And some of them are shout outs from ICUs and rehab units and research units, or just supporters who want to be part of this event. So go to the World Coma Day playlist, World Coma Day 2025 playlist on YouTube. They're all up now and they're going to stay up. So with that, I want to turn it over to Kapil, who is our chair of the chapter, and I'm looking forward to this session.
Yeah. Good morning to everyone, and thanks, Claude, for a wonderful opening remark. And I know how passionate you are about the World Coma Day and overall awakening the coma. That concept still we are promoting since 2019. So without wasting time, we'll start our today's program. So I invite Dr. Prashant Kumar, who is the current president of the Society of Neural Care India (SNCC), and he will introduce the topic, and then we'll move ahead with our webinar topics. Prashant, over to you.
Good morning, all. Namaste from India. And this is such a wonderful day to start with the Curing Coma campaign on World Coma Day. And this is something so unique from the Neurocritical Care Society, which launched Curing Coma in 2019. And it is a signature clinical, scientific, and public health effort. So it's an amalgamation of all the things which are required in medical science as well as art with the patient. And this is the most significant step we consider in terms of as a global public health initiative, which will be tackling about unifying the concept of coma as a treatable medical entity. The central goal for curing coma is to develop and implement coma treatment strategies that improve human lives. So what we are dealing is human lives. It's not only about the disease, it's about the human in every life which we have in our hospital and in our ICU. This is a very significant event which signifies the strong organizational commitment of to addressing the issue of coma, and every healthcare worker is equal part to it, whether it's an intensivist, physician, surgeon, or a nursing or a physiotherapist. So anyone who deals with a patient who is in coma is an important and integral part of it. This all suggests about the society perceiving the gap, uh, how the coma has been approached historically, and then the initiatives coming up about the coma family living in dilemma whether our patient is going to live or not live, how functionally good the patient is going to become or not. The aim has changed now with curing coma, and now we look every life as a life and look at hope. So what it has come as, it's a amalgamation of science and art, bringing the hope for victims with prolonged disorders of consciousness, not only after brain injury, but otherwise also. Now, looking at the coma, this initiative acknowledges that the coma is unique, modern clinical challenge, which may be a direct consequence of our ability to maintain life support and fight death. Now, this implies that advancements in medical technology have led to the increased prevalence of individuals in a state of coma, and we all, as healthcare professionals, have to look into it as how we can take this challenge. Also, this coma, which has always been fascinated and always challenged the humanity, can be tackled with this first ever global public health initiative, which is focused on treating coma. It also focuses on the modern challenges which are resulting from advancement in life support, and it also looks for coma being an increasingly significant challenge. What is there is desire to offer hope and improve outcomes for individuals which have prolonged disorders of unconsciousness. So today's program, we are fortunate to have with us from different societies comprising Asia Oceania chapter of Neurocritical Care Society. And to guide all of us, we have Dr. Claude Hemphill, who is the co-chair of the Curing Coma campaign, and he has been the past president of NCS. He brought out the concept, he took the society together, and he has led the program from front. Thank you, Claude, for joining us today. We also have Daiwai Olson, who is from the NCS and leading the program globally. We also have with us Dr. Kapil Zirpe from Indian Society of Critical Care Medicine, present president of Asia Oceania chapter. Then for the panel, we are joined by Dr. Leena Lakshmana from Philippines, Dr. M. Radhakrishnan from India, Dr. Saurabh Anand from India, Dr. Masao Nagayama from Japan, and Dr. Yash Javeri from India as Secretary of Society of Neurocritical Care. So first, we'll listen to Dr. Masao, what he has to say about the program, and then we will move to our esteemed panelists for the discussion on such an important topic today.
Both risk and crisis management are critically important. However, especially in the medical field, unlike risk management, crisis management has not been paid attention, especially in catastrophic neurological disease like acute coma. Today, I'd like to present about the crisis management of acute coma at the onset. Risk management starts from mitigation and prevention, goes to preparedness, prediction and early warning of the disaster. On the other hand, crisis management starts from impact assessment, response, recovery, and reconstruction. Crisis management is often expressed as damage control. That is, that decreases the damage after the event. This slide shows simulation-based education in medical safety. Chief steps is well known as the education of the risk management. Also, RRS, rapid response system, is also well known. This is kind of crisis management just after the insult or the event. Post-accidental response management was developed by us about 10 years ago and very widely used in the education of crisis management. Risk management and crisis management are usually not discriminated and confused in the catastrophic neurological disease, especially including acute coma. Crisis management is not paying attention so far, unlike risk management. It will take time to discover novel treatments to improve the outcome of acute coma. However, education of citizens can rapidly improve the outcome in every country, especially including low and medium income countries. This slide summarizes those patients at risk of disorders of consciousness. Important one is described in red letter. For example, alcohol. Heavy drinker is at risk. And not only the current one, but also pastoral drinkers have some kind of risk for disorder of consciousness. And stroke, especially hemorrhagic, and epilepsy and seizure, or not only convulsive but also non-convulsive ones, also risks, and dementia, and brain tumor, and atrial fibrillation, AIDS, malnutrition, sleep apnea syndrome, and those with past VOCs, those taking critical medications. This slide summarizes the education preparedness for a VOC. Stairs top and those places cannot be easily found should be avoided. And in cases of bathing, swimming, and super, ask family and so on to pay attention. Also avoid rapid temperature change. Standing.
Prashant, you're around?
Yeah, I'm sorry.
Yeah.
The voice probably isn't getting transmitted well, so we have stopped it. What Dr. Masao has given in his message is about crisis management, and what he is talking about is crisis management, where we generally ignore and get ignored for the while we look at the risk, the crisis is looked, which is generally considered the same as risk, but they have to be discriminated. And potential risk of risk disorders of consciousness, he has labeled as that we need to look for the risk factors for atherosclerosis, looking for the heavy drinkers, looking for the ischemic or hemorrhagic neurological diseases, epilepsy, seizures, as well as brain tumors or atrial fibrillation. Others, the malnutrition and age also looks as a risk factor. The disorder of consciousness should also be prepared. We have to be prepared for avoiding all these by looking for the places to be avoided, like stair stops, looking at the family to pay attention at the bathing and swimming, avoiding strain at lavatory, avoiding excessive alcohol, avoid sleep shortage, and obviously looking for the risk factors for blood pressure and neck massages. Also, what needs to be looked as is always in case of difficulty, should shout, make a noise, move to a safer place, in the bath, turn off switch and come out, leave symptoms on record if you record anything or you feel anything. Moving the patient to a safer place is also always a good idea. Evacuate food in the mouth because a patient might choke. And then, or in case of cardiac arrest, look for the CPR early and give good chest compressions and use of AED. So we can make a great difference rapidly in terms of outcomes for catastrophic neurological disease, especially including coma, and by education of citizens in every country, regardless of whether we are in low middle income or high income countries. So that was the message from Dr. Masao. And uh, with this message, with this start of the day, I'll hand over to Dr. Kapil Zippe, who is president of Asia Oceania chapter for NCS, to take us forward towards the discussion with all the esteemed learned panelists what we have.
Yeah, thank you, Prashant, for summarizing, because we really struggle to listen because of the voice quality. But of course, we'll post this video on the NCS website, so attendees can go through, listen it, and try to get the message what Dr. Masao is trying to reach at us. So we'll move to the next part, is panel discussion. Let me share my slides. So just give me 2 minutes. 30 seconds, not 2 minutes. 2 minutes will be the too much. Okay, everybody able to see the slides? I hope it is in a full. So all of us know that coma word itself is a very unreliable word, and we use it left and right in low middle income countries like India. In fact, it was defamed very badly by our movies and dramas by using them to take over the leap, and that was one of the reasons the society do not understand the coma, and mostly we also carry forward the similar terminologies in day-to-day practice. So we have selected very carefully the on the background of the today's World Coma Day, uh, understanding of the coma, how we looking it at with the angle of the developing nations like low middle income countries. Now, for this particular topic, we have the esteemed panelists. I will introduce them one by one. First one is Dr. Claude Hemphill. Ideally, I don't need to introduce him, but it's my responsibility. Dr. Claude is passionate about the Coma Day or the word coma, and he is doing so much work since 2019. He's a professor of neurology and also the director of the neurocritical care at the San Francisco General Hospital, and he's a founding director and the past president of the Neurocritical Care Society. So he's the one who is carrying the responsibility of this awareness, awakening hope on his shoulder. And I'm sure with the help of the everyone, he will succeed in his mission, and it's continue. It's a continuing effort. It's not the one day effort. Then our second panelist is Dr. Masao Nagayama. He will join soon, but otherwise some of the panelists will speak on behalf of him. He has some issue with his laptop. Masao Nagayama is a professor in Department of Neurology, Critical Care Medicine and Preventive Medicine from the International University of the Health Welfare from the Narita Hospital, Japan. He's a very active member of the NCS, and currently he is on editorial board of the Current, who is the official newsletter of this thing. And I know the Dr. Masao since last almost 8 years, and I know how enthusiastic he is regarding the spreading the word about the neurocritical care, and he's one of the panelists for that. Then we have Dr. Radhakrishnan from the Bangalore. He is a associate professor of Department of Neuroanesthesia from the NIMANS, that is the National Institute of Mental Health and Neuroscience. And he's also one of the very active member in India in neurocritical care and the neuroanesthesia. So we'd be eager to know his views on this particular topic. Then our fourth panelist is Dr. Saurabh Anand, another very enthusiastic neuroanesthesia critical care, and he's all the time spreading the word about the neurocritical care. He's the neuroanesthetist at the Artemis Hospital, Gurgaon, and currently he's representing the Neurocritical Care Society of India. Radhakrishnan will be representing the SNAC, that is the Society of Neurocritical Care and Anesthesia. And then we have our next panelist, Dr. Leena Lakshmana, and she is currently the vice president of the Philippine Neurocritical Care Society and the second VP of the Stroke Society of Philippines. And also she heads the Institute of Neurosciences of the St. Luke's Medical Center Global City. So with this introduction, I will move ahead, and myself is Dr. Kapil Jirpe. I'm chairing the Asia Open. I'm not the president. I'm chairing the Asia Ocean chapter on behalf of the ICCM, Indian Society of Critical Care Medicine, and also I am the board member of the NCS. So when we talk about the coma, the NCS runs this activity Curing Coma campaign since 2019. They come up with the publication, and through that they try to explore the various aspects of the coma. We need to know what is mean by coma, whether to use this terminology is the right or wrong, what are the alternative to the this terminology. And through this, this is not limited to the medical fraternity, this is not limited to the only specialists. This particular terminology is related with the common people, public. We need to reach to the common people also, so we have to educate the common people, we have to educate hospital administrators, we have to educate medical fraternity, we have to educate the stakeholders from the even the those who are making the laws and this thing. So we need to involve everyone to create awareness regarding the coma. It's not negative. It's not necessary every time it is has a negative results. It majority time it might be the positive. You need to reach to the diagnosis in a right way with the help of the newer technologies, and utilize the your available biomarkers and the technologies to give them the prognostication. That's entire activity, the curing coma campaign. It is nothing to do with the only diagnosis, or nothing to do with the only prognosis. So this is a diverse group of the people who are working in this coma terminology, like a scientist, neurointensivists, neuro rehabilitators, along with the other stakeholders, can come together to promote the coma. And this was I will request everyone to go through the this particular article, the Curian Coma campaign, the framing initial scientific challenges. It was in a 2019, and they have very specifically mentioned the three major pillars of this coma. That is endotyping the coma, disorders of the consciousness, and the biomarkers, and the proof of concept clinical trial. Around this entire publication is there. Now, when I gone through this particular publication, I realized that there is a hardly any representation for the middle income countries. So whether it is applied to the low middle income countries, or we need to explore how we can better try to understand the situation in our area. And that's the entire purpose of this particular campaign, with the perspective of the low middle income countries. Because if I'm not wrong, hardly 8% or something is representation from the low middle income countries with this participant point of view. That is too low, and that also gives us idea that how much we are aware about this particular concept. We need to wake up now. It is awakening coma, but we need to wake up now to understand this particular terminology. So on this background of the this coma campaign, we'll move ahead with the first one. And the first was, I have to involve the Claude in this, because he is the one who has pioneered this concept, and he's working throughout day night, I will say. I'm not exaggerating, because I had an opportunity to speak with him in last year in Chennai, and I realized how passionate he's about. He's ready to share the slides, he's ready to share the material, he's ready to share any ideas is available. So uh, uh, Claude, what is the purpose behind developing this classification of the different coma endotype? It is related with the diagnostic, prognostication, or entire concept of the coma?
That's Kapil, I'm really glad that you brought this up, because it's one of the central issues that I think we realized that we were facing with regard to trying to focus on potential treatments for coma as a entity that where we could target mechanistic interventions for purposes of recovery, and probably also improve the ability for prognostication. So the idea is the way we tend to, first of all, diagnose and prognosticate with regard to patients who have severe disorders of consciousness, especially in the acute setting in someone with traumatic brain injury or stroke or hypoxic ischemic brain injury after cardiac arrest, is largely based on what they look like at the time, what their neurologic examination is at the time. And that's phenotype, what somebody looks like. And that's a snapshot in time. But really, what endotype is why they look that way. What is the underlying biological mechanism for the phenotype? And so we know that many patients who are in deep coma do not recover, and at least with our current interventions. And we know that many people have the potential to recover, and these patients may look the same at that particular snapshot in time. So really what we're talking about is a biological, underlying biological diagnosis. Now this is challenging, especially when we're talking about current diagnostic methods for this. And I think this is one of the reasons why coma has been everywhere worldwide, regardless of low and middle income countries or other resource countries. Why we haven't cured coma yet? Why it's such a problem? Is because we haven't had methods to really assess the underlying biological mechanism. So one mechanism could be circuits, the default mode network, or other networks that relate to consciousness or awareness or other aspects. We know that we're beginning to be able to investigate this with advanced techniques such as functional MRI and advanced EEG, which still, even in my hospital, are still research tools. They're not able to be used in clinical care, but they're telling us something underlying about patients. And it's really interesting too to start to see sort of perhaps more focused aspects of the neurologic examination that may assess this. Pupillometry is potentially one of these. There's a study going on looking at eye movement glasses that would assess eye movements, and that would really, the purpose of that is to more precisely assess brainstem dysfunction. So that's sort of a lot of discussion around this, but the point is, if we're going to find treatments, the treatments are going to have to be based on endotypes, not just the phenotype of what the patient looks like at the time, because we just can't tell whether that patient has the capacity for recovery or not by just doing a neuro exam, at least the way I've always done it.
Yeah, excellent way to explain. And what I like, you said that the coma is the same everywhere, whether it is a low middle income countries or whether it is in USA.
Yeah.
We need to diagnose it, we need to endotype it, and that's what this article you have mentioned, that start using the terminology disorders of consciousness rather than the coma. So we are in a better situation to understand this terminology by disorders of the consciousness, like whether there is a structural damage or there is no structural damage, or there is a not amenable to a pharmacological anatomical replacement, or it is a mimic endotype, and that gives a lot of idea. And that's what you are saying in terms of the MRI, functional MRI, EEGs, and like that we can use the neurological exam, your imaging and the biomarkers to come to the phenotyping, whether it is a reversible or whether it is a irreversible. Like disorders of the consciousness without structural damage is like metabolic coma, or those who are the drug overdoses, where you will not find any structural damage. And in terms of the structural damage, like a stroke or traumatic brain injury, so it will be easy for for us to understand the phenotype, and accordingly you decide the endotype on the basis of the your clinical examination and imaging, so that we can at least those patients who are looking and fitting into the same type maybe differs in a prognostication, and that's why one need to start using the proper terminologies and doing the endotyping. Now, with continuity of this, Dr. Lena, you are around?
Yes. Yes, sir.
Yeah. So up till
Okay.
now, up till now you must have gone through the discussion, and
Yeah,
in
yeah. Thank you
continuity,
so much.
in continuity with the Claude, how smartly we can use the biomarkers to do the assessment of the disorder of consciousness? Which are the biomarkers are available? How you do in your practice, and how you make the combinations of the biomarkers or addition of the biomarkers to get to the nearby that particular endotype and give the better diagnosis?
Yeah. Yes, there are really biomarkers, no, that will really help us assess in the among patients with consciousness. And yes, we develop trajectory models in the ICU, and probably in the future it can help us prognosticate our patients. So I agree with Dr. Claude. There are really situations in which for example, MRI, functional MRI are still in research practice. Like in the Philippines, we're trying to develop one, but hopefully after we gather, patients, we can then adopt it for purpose of clinical practice later on. So let me just enumerate some biomarkers which we have on hand, both international and usually local. No, so at rest we have, of course, we can assess the brain structurally using imaging study, and this can be CT or MR. We also have neuronal assessment like spectral analysis or permutation or spectral complexity and resting EEGs. We also have functional connectivity, just like Dr. Cloud has mentioned, through EEG and functional MRI. Now, functional MRI, remember, can also be used passively through stimulation-based, or it can even help us for task-related studies through commanded motor acts, for example, or imagery, or even spatial navigation. What are other biomarkers? We can already measure the brain physiology, for example, metabolism through PET scan, FDG. We have oxygen, brain physiology, wherein Lycox can be utilized. Blood flow can also be utilized through CT or MR perfusion imaging. There are also ways of measuring directly your ICP through monitors, as well as CPP, cerebral metabolites, like in the use of microdialysis. And lastly, reflecting injury to the brain or impaired cerebral autoregulation can also be measured through CSF or serum. And these are usually biomarkers for NSE, neuron-specific enolase, S100B, GFAP, which, by the way, the Philippines don't have all of these measures yet at the moment. Now, how about passive tasks, perturbation tasks? This can also be measured by evoked potential studies like your somatosensory, motor evoked response, or your brainstem auditory evoked response, and other event-related potentials that make use of cognitive processing, as well as your modulation of your autonomic nervous system. TMS with highly density EEG co-registration can also be used. Now, let me go back with what Dr. Claude mentioned. Actually, behavioral assessment is really just one of the first assessment that we use for patients who come in with decreased level of consciousness. And in this coma recovery scale, revised is the most validated scale to actually differentiate vegetative state, which is now called unresponsive wakefulness state, versus MCS, or minimally conscious state. And as you know, this comprises six domains. No? Basically, your auditory, your visual, oromotor, communication, motor, arousal. That will also tell you how patients will probably behave later on. There are also other less comprehensive clinical scores for behavioral assessments, such as your GCS score, for example, and your 4 score. And lastly, I already mentioned earlier that functional MR can definitely will be helpful, but again, institutions may not really have this MRI procedures just yet, but we are slowly developing, and hopefully this will be available to us in the near future. Thank you.
Exactly.
Thank you.
Excellent, excellent. That's sort of my question. We all talk about the functional MRI. How easy it is available in Philippines and surrounding area, and what might be the timing of the functional MRI. We need to speak about
Yes.
when to do the functional MRI rather than otherwise it might get some different opinion carry forward. So what you will look at the availability of the functional MRI and the timing.
Oh, the functional MRI, as far as we are still in the construction phase, because as early as now, we are actually just targeting trauma and some sort of tumor, brain tumors. But as to the timing, I still have to coordinate this with our team, specifically the neurosurgeon and one of our memory specialists in St. Luke's Medical Center.
Yeah, that's a major issue in a low middle income
It's
countries.
an issue.
Availability of the functional MRI, and that might be the one of the block in so bottom line, we need to know about the biomarkers, and we need to know why we should do the biomarkers to make the diagnosis, do the prognostication, and then you can develop the your plan of the action according to that, and you go on doing the various combinations. It's not like that once you did it, it is more than enough. Might be it has to be the frequently with the certain gaps you need to repeat them, and just try to assess that key you are in the right track in the reversibility of the coma, and you can assure the family. At the end of the day, we need to maintain the moral of the family regarding the treatment part. Yes, it is reversible. He or she might come out, and we need to hold our nerves and keep a lot of patience, and that's the entire idea, and that's where we are probably in low middle income countries are struggling for getting those things to get the better and better diagnostic and the prognostication in coma. Thank you, Dr.
Thank you.
Nina.
Thank you. As of now, we're just into the imaging study, CT and MR.
Okay. Yeah, that's what the similar situation in India. Now moving ahead with the on the same path, Dr. Radhakrishnan, like Dr. Leena mentioned, there is a lot of issues regarding the abilities of the various technologies, diagnostic methods in the Philippines, and I'm sure India is a diverse country. Few areas might have the excellent top quality diagnostic facilities available with the biomarkers, but few areas even there is a scanning is not available. So what you feel overall, which are the various stumbling blocks in India related to the India, which we can address in future for the meaningful outcome? Because Let me address to the audience that in India, the more than 50% of the load of this coma patient is a traumatic brain injury. And then second leading cause is the stroke, and third in SH, and then like that. So we need to improve those technologies so that we can offer them the better early diagnosis and the treatment and the good prognosis. So over to Dr. Radhakrishnan.
Good morning. The first stumbling block is understanding the spectrum of disorders of consciousness by the healthcare professionals. The terminology keeps changing. Then the doctors must be well aware of the spectrum and which one has a good prognostication and which one is poor. So that is the first stumbling block. So to separate these patients, we need advanced MRI imaging, especially to identify cognitive motor dissociation, which in the long term have a better recovery. Now, our country has a lot of MRI facilities, but when it comes to like functional MRI and then task-based MRI, not many people are trained it. Currently, the MRI focuses on identifying the structural lesions, not this high-end functional MRI. So the radiology, the people who run the imaging, they also need to be trained. One way to overcome is using the teleconference or telemedicine facility where there can be a central area where these things like EEGs and MRI can be transferred for better interpretations. Third, for the government to formulate any policy, it has to know the burden. Now, in the ICMR maintains a cancer registry. Now, the government focuses on non-communicable diseases mainly in terms of prevention and early recognition. Now, coma is a consequence of other injuries. So we don't have a database so that the government is not able to frame a policy or allocate fund. Now, why is this happening? You know, in India, majority are of a migrant population who move around for work. So whenever a brain injury occurs, they get treated, but then due to economic reasons, they move out to their native place. So we lose patients to follow up. So we cannot track these patients. And in India, the treatment facility happens in the nursing homes, tertiary care hospital, government hospital, or in the home. So it's very difficult to follow up these patients to know what happens to these patients. And most importantly, the treatment happens either in the hospital or in the house. We don't have any intermediate between the hospital and the house. Now, there is always a shortage of ICU beds and the hospital beds. So the patient comes to the ICU. Once ICU care is over, they move to the hospital. And from the hospital, there is nothing called as rehabilitation centers. They have to go to their houses for the long-term follow-up. So many patients lose their life because of malnutrition, infection, because of economic reasons and financial burden. So we have to think of developing some rehabilitation center which is non-doctor but mainly of musical therapists, occupational therapists, rehabilitation physicians who will be able to take care of these patients, because it is very difficult to say when these patients will recover and how fast they will recover. So they need some long-term care. So these are the few stumbling blocks which I feel which needs to be overcome to maintain uniform diagnosis and treatment options.
Dr. Radhakrishnan, you hit the nail. Let me tell you, in a short time, you try to cover the entire 1 hour talk, like community to the pre-hospital care, to the emergency medicine, to the ICUs and post-ICU discharge. You try to cover the entire chain of the events related with the disease processes, the major stumbling blocks. And what you said is very right. Recently, there was one paper in a Lancet from, I think, Vellore. Dr. Shalini is the author. She has published the trauma registry, and you will surprised to know the 71% of those patients, something a few thousands patients were there, were the two-wheeler accident. And out of that, only 7% were wearing the helmet. So you can imagine that at what level we need to make awareness. And you rightly hit the nail that the government agencies are interested in making the policies for the non-communicable diseases and the prevention and prophylaxis, but we need to know that what is the burden we are facing in India, what is the burden on the government. At the end of the day, government is spending a lot of funds on this. So we need to reduce, we need to work preventive measures. I think if the more than 50% is a traumatic brain injury load in India in terms of the coma, and if this is a situation like this is a one sample size, this is not the pan India, but still it is very eye opener. Government, we need to go to the government and request them to work on this to prevent. I think prevent will make the major success in reducing, and that you rightly mentioned. And I like the last part is the post ICU discharge. Let me tell you, this is the one of the weakest area in our medical system. We do not have adequate. In fact, we do not have. Not, I will not say adequate. Sorry to say the some blunt statement, but we do not have adequate neuro rehabs. So what happens to those patients who are just recovered from the coma and they need proper follow-up and the proper treatment? Probably they are majority time they are malnourished, what you rightly mentioned. So many areas we can work in India, and of course, I'm sure in Philippines, in Nepal, in Sri Lanka, in Japan, it must be the similar issues, scoring one on the another. Thanks, Dr. Radhakrishnan, for enlightening us on a very serious issue related with the stumbling blocks in India. And with this in continuity, Saurabh, I think Radhakrishnan has made your job much more easy. But still, I would like to ask in a different way, what are the barriers for the management of patient in coma? Now he has given you the entire listing of the issues. So which are the barriers? Where are the major barriers? Why we are not moving ahead in improving the survival of the coma patients?
Hi, hi to all. And I think Dr. Radhakrishnan has rightly put down each and everything in a very, very crisp way. I would just like to elaborate that there is nothing gloomy all over India, or I will say LMIC. We are improving. I'm not saying that we are not improving on that traumatic front. Also, if you look at our road transport minister, he has said that every car which is coming right now should be with 6 airbags. So they are worried. The government is also forming policies, but they are doing it in their own possible way. And if we have some representation, a common representation from us, and then we are going to provide them with the adequate data, I don't think that they will be deaf ear to that. Now, coming to what are the barriers, I will say the first important thing will be the resource. Now, resource, I always mean first and the foremost thing is the human resource. Now, human resource, I will say shortage of not only the trained neurointensivist, but I will say the healthcare providers also. The shortage of the trained nursing specialists and the inadequacy from our part also to train them so that they can actually provide a good care right starting from the emergency level. Then, as everybody told that the second resource limitation is about the equipment. We all know that the cost of care, hospitalization, diagnostic test, medications can be prohibitively expensive in families of LMICs, and many patients are not able to afford a long-term care in these patients, and that is why Dr. Radhakrishnan rightly pointed out that these patients might be transferred to bed or home care, and they are lose to follow-ups because we don't have in between a good neuro rehab center or a center in which we can provide the same level of care with a lower down cost. Third most important thing which I feel is the education of family members. Now, education of family members, we need to take this coma care to the public. Okay, we are meeting once in a year and discussing about all the issues, but have we taken this care and have we taken this campaign to the public awareness as well? We need to do some public awareness campaign regularly, maybe on a head injury day, maybe on a epilepsy day. We are doing that, but in a very, very minuscule amount, which is actually I will say negligible. And if I will say that I can say definitely this about India, there are some social and cultural barriers also. In certain regions, I will say the cultural beliefs and stigma around the brain injuries may provide individuals from seeking the appropriate medical treatment. They might influence how the treatment is administered in India, and the social support family in low income countries may struggle the burden of caring for that coma patient, both financially and emotionally, I will say. And social structure, though it's I will say the better in India, but the caretaker has got all the burden right from the surrogate decision making to taking care of the cost. So I will say, whether from an infrastructure and environmental barriers, from the barrier point of view, the resource limitation barrier, from that source, whether it's a shortage of medical personnel, whether it is a combination of all these factors, is I will say the main important thing which we need to take care of and take it to the families and educate the people around us.
I agree. I agree with the word what you mentioned. In addition, we have the major issue is regarding the funding, regarding the most of the our patients are paying from their pockets. The insurance services are hardly 8 to 10%, if I am not exaggerating. So that might be the one of the major reason or block in our this thing. And but otherwise what you said is right, is the we need to have a better and better prognostic tools like imaging facilities. We need a better resources, better trained doctors, nurses, and better neuro rehab. That will be also the reducing factor. So almost we have discussed the every aspect of the coma related issues or disorders of the consciousness issues in a low middle income countries. Now, I don't know, Dr. Masao is, I'm not able to see him. Probably he joined as an attendee. I don't know whether he has access. So I will open up his questions to everyone. Whoever would like to answer this, uh, it's welcome. So now let's summarize the issue. What measures to enhance the success of the curing coma campaign in low middle income countries? Now, would like to summarize the whatever we discuss, and then I will come to the Claude for the final comments, because now he's a balance. He is a balance which he's working in the developed countries, and we have put forth the every issues related with the developing countries, and now he can give us a balanced opinion regarding this campaign. Dr. Radhakrishnan, Dr. Saurabh, or Dr. Leena, will you please give us just briefs in 1 or 2 minutes regarding the how we can move ahead? We need to move ahead. We can't just discuss the only blocks and the barriers.
Okay. I'll start
So
first.
Yeah,
okay.
please, Dr.
First, the knowledge must start from teaching the undergraduate level. There's something called as disorders of consciousness, diagnostic, and it can be managed. That is number one. Number two, now many of these district hospitals are in medical colleges. They have started this integrative medicines where Ayurveda, Siddha, everything has been slowly incorporated apart from allopathic medicines. So in a similar way, a rehabilitation setup can also be added into these facilities, because all these patients are totally dependent on their relatives for the transportation. It is not like any other non-communicable disease. So we have to take the treatment to the doorstep. The only way is in the district hospital, we can start off like with a physical therapist or a rehabilitation person for teaching the patient's relative and also for the easy follow-up of the patients. The third thing is, somehow we have to form a registry wherein all the hospitals, whether it's a nursing home or a teaching hospital or a corporate hospital, some form of registry, a simple data collection to know the burden. So then it is easy for the government to formulate policies or allocate funds.
Okay, Dr. Leena.
Yeah. So I totally agree. First of all, I think that disorder of consciousness should not only be learned by medical people, people from the hospital, or even the medical students, but we have to involve the government as well. Government, because they're really support us. If we implement policy or we formulate policy, then they should help us implement the policy for all. They should also help us in terms of financial aspects as well. Now, while I understand that few hospitals only really deal with the proper registry of patients suffering from DOC. It has to also be a united activity by hospitals, not only in the Metro Manila, for example, but also within the Philippines per se. I think that's about it for now. Maybe we can also help develop through your help on how we can get our functional MRI working in the future with conferences, like, for example, conferences and other means of communication with those people who are really adept in this diagnostic test. That's it for me. Thank you.
Perfect.
So,
Yes, sort of quick.
Right,
We
could I
are
add?
now
So,
coming.
see, I think the question is how to make curing coma campaign of NCS a success. I think this is what we're addressing right now. So, if you say that, assuming that it refers to raising awareness, funding, or scientific research or treatment and recovery, the first and the foremost important thing I will say is that we should define the campaign goals. See, we still we have been attached with curing coma campaign from last 2 or 3 years, but still I will say the compelling message a personal should be relatable to everyone who has been involved, and that will I will leave Claude to answer it. And I will say we should use social media. It's not only about we are telling what to do. I think we should involve influencers. So if there are some influencers who have a great reach, maybe in India, maybe in other countries, and if they are talking about our curing coma campaign, then I think it will just spread like anything. Okay, so that's one more thing.
Yes.
And apart from that, if we talk about the educational content, crowdfunding, fundraising, it should be a multi-pronged approach and collaboration with the health institutions, whatever you say, the community engagement, I will say, we should create a support network. So there is a group for there is a community right now on social media for everything. If we create a community of that sort in India, that is a community for curing coma campaign, and we will increase our followers on social media, I think we will able to do it in a much better way. That's my 2 cents on it.
Yeah. Claude, would you like to summarize the entire discussion?
Well, I would just say I love this because this is how I learn. I mean, I learned from you guys, and just that my last trip to India, where I was able to to talk about this and brainstorm and learn. It's great because the lessons that you're talking about, and I really like the fact that the first approach was say we've got to figure out. It was not we've got to figure out how to get a functional MRI scanner in every hospital. That's not the answer, and that's not the answer in the U.S. That's not the answer in Europe. When you're talking about education and you're talking about education of physicians who are not as knowledgeable about neuro aspects, but also nurses and the public, and to try to get data of coma prevalence and the trajectory of patients and some where they what their improvement level is or is not, but also where they go and how we would potentially reach them for these other interventions. So, these are things I'm taking back with me because these are things that we need where we are. And so I think that's actually a common lesson. Now, I think that I've really thought a lot about this. What are the goals of the Curing Coma campaign? And in a very practical way, one of the very tangible goals is to identify a specific treatment based on a coma mechanism that can be administered to patients that they recover. Some patients will recover. But I'll tell you what I really think the goal is. It's actually culture change. It's actually culture change. It's moving from a notion that coma is a death sentence, coma is unrecoverable, coma, there's no point in knowing more about why the person's in a coma because there's nothing that's going to happen about it. And we know that that's not true. So that's this notion of awakening hope as the phrase of the Curing Coma campaign is not based on a naive sense that everybody's going to recover. It's about culture change for the possible. And I think that you've been talking about that the whole time. So that's my sense.
Yeah. So with this positive note, we will end our discussion. It will go on, and it is not the one-time story. We need to continue it in such a discussions on the various platforms, practice in our day-to-day life, associate with the various social media, like Saurabh says that, and try to find out if any influencer is going to help us to create this thing. We might communicate with our film industry and just educate them, because they are the one who are spoiling the entire meaning of the coma. Well, coma is something like disastrous. Over a year they are doing it. They are doing it over the 50, 40 years, and we need to, at least 5 years, we need to follow up with them. So with this positive note, I think we need a lot of research. We need a lot of our epidemiological data, that what the Dr. Radhakrishnan said. We need our own data to understand which are the burdens on the society as well as the government, and approach to the government agencies on that background and create some preventive measures. And as Dr. Leena said, regarding the functional MRI and diagnosis facilities, we need to work a lot. I think the everywhere situation is similar. We have to move ahead with the positive note. With this, I thanks my all panelists for their time, as well as the excellent overview as well as the discussion. Now I hand over to the Dr. Yash Jawhari for summarizing and giving the vote of thanks. Thank you.
Thank you. Thank you, Dr. Zetpe, sir. At the onset, I'd like to thank Neurocritical Care Society, SNCC, IACCM, Neurocritical Care Society of India, ISNEC, and Philippines Neurocritical Care Society for their inputs. My special thanks for Dr. Claude for rekindling the hope, and we could sense your passion, and it's so infective. So lot of us will be imbibing the passion and taking the flame forward with you. Thank you, Dr. Leena, Dr. Masao, Dr. Radhakrishnan. Dr. Radhakrishnan highlighted how to bring the issue to the front burner, how to engage the community, how to educate the healthcare providers from the beginning so that they learn the right meaning of coma and imbibe that in their practice. Dr. Saurabh highlighted the need for having brand ambassadors and community engagement. This is very, very important. Probably we need to take that forward. And Dr. Leena taught us that disorders of consciousness should be based on biomarkers and endotypes. Functional MRI and brain physiology are very, very important in doing the complete diagnosis of coma. What we do incomplete diagnosis of coma. We also understand that coma is a public health hazard. It might not be very big as cancer or sepsis, but still it's a big public health challenge in terms of cost, morbidity, and mortality. So we need to diagnose coma in the right sense. We need to prognosticate correctly and objectively to the family so that they are prepared for the outcomes and they do what is required. With this, I'd like to thank everyone, especially Dr. Zirpe and Dr. Claude, for enlightening us on this World Coma Day. Thank you.
Thank you.
Thank you. And thank you, NCS, for giving us an opportunity to present our Asia Ocean chapter. So I take this opportunity to
absolutely
appreciate and thank the NCS and the president for giving us an opportunity. Thank you.
This is great. Appeal, everybody. This is great. Thank you.
Thank you.
Thank you.
Looking forward to the rest of World Coma Day.
All right. Yeah, sure. We'll continue.
All right. Y'all take care. Thank you.
Okay.